Hi everyone, my name is Lisa Maciejewski and I'm going to be your facilitator today for this webinar on telemedicine, provider enrollment updates, and next steps as we navigate through the COVID-19 crisis and as we continue to work our way back towards a regular work week and normal business time. So I just want to thank you for, for attending. I want to thank AMI for putting this presentation on for us, and we really appreciate you hosting me for this very important topic. So, we're going to talk about a few things today, and as I said, my name is Lisa Maciejewski. I'm the president and owner of Gold Star Medical Business Services, and I'm affiliated with AMI. We have a wonderful working relationship where I help the AMI clients with their billing and coding and compliance issues. And so we have been partnering together for the last couple of months to, to have us present some important topics for you all to learn about, as it relates to the COVID-19 crisis. And our goal is to keep you busy and keep you working and keep you profitable. So let's get going. We're going to talk about a number of different things today. Our few discussion points are going to be, number one is an update on the 1135 waivers. And if you've taken any of the other webinars that I have given for AMI and also for myself and my clients, we've talked about these 1135 waivers and how they have affected healthcare in the United States during this COVID pandemic. We're also going to talk about what's new with telemedicine and how we keep using telemedicine as we get back to work, which is a super important topic as well. And then we will finish up with some updates to the DME and Medicare Part B enrollment and what we need to do to transition those provisional enrollments to a permanent enrollment as the public health emergency designation is lifted. So the first question that I get quite a bit from clients is when are the 1135 waivers ending? And there's some talk and some chatter out there stating that the waiver is supposed to end on May 31st. And so I wanted to dispel that right away, because the waiver is going to be in effect for as long as the public health emergency designation is in place. So as long as we're under a national emergency, the 1135 waivers will continue. Now, the Department of the Secretary of the Department of Health and Human Services has to renew these waivers every 60 days. But at this point, what we understand is that these are continuing to be renewed and updated on a almost daily or weekly basis. Now, during this time, and right now we're on it's May 12th, and so we're several months into the public health emergency. President Trump has now unveiled guidelines for opening up America again. It's basically a three-phased approach based on the advice of public health experts on how to get back to work. And depending on what state you're in, you may still be under total lockdown, or you may be on, where it's almost business back to normal, and you're seeing restaurants opening, and you're seeing nail salons opening, and so on and so forth. And so depending on where you're listening from, you may be in a completely different situation than another provider. And the thing to remember is that even though we may be at different places in our country as far as what, depending on what state you're in, you may have much looser restrictions from the standpoint of whether you can see patients in your clinic, whether you can see them unrestricted, whether you have to practice sterilization techniques and continue to use personal protective equipment, or whether you now still cannot see patients in your practice. the designation of the public health emergency is still the same for everybody. And so the rules for provider enrollment, the rules for telemedicine have not changed until the public health emergency has been lifted. So what this means for us is that the provider enrollment waivers are still in place. It means that you can still get same-day Medicare Part B enrollment. It means that you can get expedited DME supplier enrollment through Medicare, meaning there's no fees, there's no background checks to become a DME supplier or to be able to provide bracing for your patients through Medicare. The telemedicine waivers are also still in place. And that means that you can provide telemedicine services to patients in your home. The waiver has expanded the types of providers who can perform telemedicine services. HIPAA has relaxed its regulations as far as privacy and security goes, and you can provide telemedicine services using common platforms such as FaceTime or Skype or Zoom. And the code set for telemedicine has expanded significantly to where now there are over 244 codes that are approved for telemedicine through visual means, and over 91 codes that are approved for telemedicine over the telephone. And so, you know, all of this is still available to us as providers to be able to provide services for our patients in a different way as we navigate through this COVID-19 pandemic. So what we're going to talk about first is telehealth. And we have some things that are new to telehealth. And again, if you have listened or watched any of the webinars that I've done, one of the things that I've tried to stress is that this whole situation is extremely fluid. And so sometimes I can present content or a topic that is relevant today as of May 13th, and then in 2 days, it may not be relevant because a new set of rules or a new set of regulations or new updates may come out. And so I do want you to always make sure that whatever you are seeing on your screen, you're verifying through CMS that this is still in place or these rules are still applicable to you. So on April 30th, CMS really made some amazing improvements in telehealth. They added 91 CPT codes that can be billed through telehealth if you do it over the telephone only. There are 244 codes on the telehealth listing for audio or visual telehealth services. And they actually took the telephone evaluation and management codes 99441 through 99443, and they tripled the payment amounts for those phone visits to equal a face-to-face encounter, which is huge. So basically, if you would be seeing a patient in person and doing an established patient exam as a 99212, you could do an equivalent one over the phone as a 99441 and get paid the same amount. Whereas prior to this waiver, the reimbursement rates for telephone evaluation and management services was pretty insignificant. It allows you to use your timing for telehealth documentation. So for example, if you are seeing a patient in 99212, a level 2 established patient exam, and that exam indicates in the CPT code book that you would expect that to be about 15 to 20 minutes, then that time would qualify for that level of code. All right, so that's pretty cool. It also confirmed modifier 95 for Medicare Part B telehealth services. So what that means is that if you are doing telehealth services and you use or any CPT code and you put modifier 95 on the claim, it means you did it by telehealth. You'll get paid the same as if you were performing the service in person. If for some reason you're doing COVID specimen collection, you can now use code 99211. And the same place of service code that you would use for an in-person service is what you would now use for your telehealth codes. So for example, if there is a place of service code for telehealth of 02, that means it was done by telehealth. And now what you can do is do your place of service code as an in-person visit in the office, which would be place of service code 11, even though you're doing telehealth, and you would get reimbursed at that rate. So you're going to get reimbursed at the maximum rate that you can by doing the telehealth services and coding them correctly. There's some other updates to rural health clinics or federally qualified health clinics. Probably not going to apply to the majority of listeners of this particular webinar, but if you are, there have been updates to payment amounts for you as well. Now, in order for you to keep up to date as far as the rules and the regulations and the updates and the waivers, one place where you want to bookmark is the cms.gov website. And when you get on the cms.gov website, the front page has a big link that says COVID-19. If you click on that, it's going to take you into this page, which deals with all of the public health care emergencies. And I'm just showing you the very top of this page, but if you were able, and this is a screenshot, of course, so I can't show you the whole thing, but if you were to scroll down this page, every single document relating to COVID-19, every single document, regulation relating to the waivers is published right here. So if you are ever and it tells you the date of the document. So you'll see, for example, the one at the bottom of your screen says you can read the blanket waivers for COVID-19 in the list of blanket waivers, and it tells you when it was last updated. So you can keep up to date with all of the most recent changes or revisions to the COVID-19 blanket waivers by going to the CMS website. So this is a really, really good resource for you to have. So let's take a look at some of the highlights of this blanket waiver document. This was published and updated on May 11th, which is just a few days ago. And so a couple of the highlights that I wanted to point out is the one relating to when are these waivers going to end. And as you can see by the document itself, May 31st is not mentioned. The effective date of these waivers were March 1st of 2020, and they will be effective through the end of the emergency declaration. Now, when that emergency declaration is going to end has not yet been determined. It has not been announced. And I'm sure that as soon as it is, then Medicare will put together an update for that. Another highlight of this document is that the types for telehealth services, the types of healthcare professionals that can furnish distance site telehealth services now include individuals such as physical therapists, occupational therapists, speech language pathologists, registered dietitians, clinical social workers, and so on. And so there is a much broader group of providers who can render telehealth services to Medicare patients. Now, I do want to remind you that when we're talking about these services, we are talking about them in relation to Medicare. However, what we are seeing is that the majority of the commercial payers have adopted these waivers. There may be some little variations depending on the payer, and you would want to check with the individual commercial payers to see what their rules are and see if they vary from the Medicare rules. So just kind of keep that in mind when we're looking at this information. Audio, telephone, E&M services are now going to be reimbursed at the same rate as live video telehealth services and face-to-face services, and that's huge. And so it's allowing for audio-only telephone and evaluation management services and behavioral health counseling and educational services. So this is really good news. And again, there's about 90 codes that can be rendered by telephone services versus video telehealth services. Another update to this relating to DME is the provision for being able to replace a DME item or a brace that has been lost, destroyed, irreparably damaged, or otherwise rendered unusable. So, you know, let's say you have a patient and they have a knee brace, and because of COVID-19, they've either been spending 2 months working out significantly, or they're spending 2 months, the last 2 months, eating their problems away, and now the brace doesn't fit them anymore, okay? Or the brace is broken. Typically, Medicare is only going to replace that brace once every 5 years. But if during the COVID-19 crisis, you can submit for a replacement by placing the correct modifier on the claim for a replacement, and you will not have to do a new letter of medical necessity or a new physician's order. You can use the original orders. And so that's good news as well. You just need to make sure you have the correct modifier, and do make a note in your documentation about that. Now, again, I did a webinar last month on billing for DME and bracing. And I know that Azon Medical with Advanced Medical Integration, they have also done some webinars on DME and bracing and implementation of DME. So we're not going to get into the weeds about that today, but just suffice to say that this is a nice update that has taken place recently. The other update that is worth mentioning is the provider licensing requirement. So CMS has temporarily waived requirements that out-of-state practitioners be licensed in the state where they're providing services. So, for example, if you're in Florida as a Florida licensed provider, and you're up in, let's say, Tallahassee area, and you've got patients that reside in Georgia, you can provide telehealth services to that patient with your Florida license. Now, there's a caveat to that, and the caveat is that the CMS waiver does not supersede state requirements. And so individual states have developed their own waivers and their own requirements for you to obtain temporary licensing privileges. So you must find out from the state medical licensing board or chiropractic licensing board what those waivers are, okay? And sometimes it's just a little application that you have to submit to the licensing board. Sometimes it's completely unrestricted. It depends on the state. There are right now, out of the 50 states and one territory, Puerto Rico, 47 of the 51 have waivers. There are 4 that do not. And so there is a website available to let you know what those waivers are. If you want access to that website, please feel free to give me a call, and I'll be happy to let you know, or send me an email and I will send you the link for that website so you can find out what those state waivers are. Throughout the presentation today, you're going to see my information across the bottom of some of the slides. Feel free to take that information down so you can call me or email me with any questions that you might have. So let's talk about embracing telemedicine. I know that, I've worked with a lot of clients, and some clients have just taken telemedicine and have absolutely run with it. And they are doing telemedicine. They're probably doing 50 to 100 telemedicine visits a week. And they're able to provide tremendous service to their patients during this lockdown and these stay-at-home orders and so on and so forth. Others have been kind of dipping their toes into telemedicine, and they're doing it on a few patients, but they haven't really perfected the process. And so for some providers, I've gotten feedback that it's a little cumbersome, it's a little difficult. And, my feeling is that anything that's new is not going to feel natural. And so unless you really commit to it, and unless you make it a point to embrace telemedicine as a new norm in the way you do business and the way you do medicine, I think you're always going to feel a little bit behind that 8 ball. You're not going to get the maximum benefit from telemedicine that you can. And there's a lot of benefits to telemedicine. Number one is it keeps you connected to your patients during the self-imposed or mandatory isolation orders. Telemedicine can help you be more efficient with your time and space if you're on a modified schedule. Telemedicine has powerful implications and applications for you even after you're fully operational. And I mean, I know it, and you know, in all of the conversations that I've had with healthcare professionals and some of the higher ups in Medicare, telemedicine is never going back to the way it was. Telemedicine is here to stay. Patients love it. Patients have responded extremely favorably to telemedicine. In all honesty, if you can give the patient an opportunity to do part of their visit that does not require hands-on or one-on-one contact, physical contact with you, then you should be offering it to them in telemedicine, because you're not going to get paid any differently whether you do it by telemedicine or you do it face-to-face. Now, for those of you who are chiropractors, I know you are just waiting until you can get your patients back into the office, and some of you already are, but you're having to be on a modified schedule. So whereas, you know, in a lot of high volume chiropractic clinics, you might be able to see 16 patients an hour, you may only be able to see 4 or 5 patients an hour because of the, you know, having to do the sterilization, having to change out your protective equipment every time you see a patient, and so on and so forth. But think about this, the activity that takes place within a chiropractic visit even, you know, I'm not talking about a medical visit, just the activity that takes place within a chiropractic visit that you could still be having your patients do at home, all right? So if you're doing a new patient exam, and I'm not just talking about Medicare here, I'm talking about commercial payers, they're paying for telemedicine. And if your Blue Cross plan covers exams as a chiropractor, you can be doing a telemedicine exam on your patient of a modified sort, but you could still be doing somewhat of an exam on those patients. Your patients could be doing their subjectives and their initial daily visit intake via telemedicine or via virtual check-in, and then come in and be seen for their spinal manipulation. So, you know, you need to start thinking about these processes, and if you can buy in 1 hour 2 more patient visits by keeping some of those activities over on the telemedicine side, then, you know, and you multiply those 2, let's say 2 more patient visits an hour by a 6-hour day, you know, that's 12 more patient visits, and you can see, and then multiply that by however much you make. You know, you're talking about some significant income each week and each month that you could be generating by doing telemedicine the right way. So this is a pretty cool algorithm that I found on how to choose the correct telemedicine visit for the type of visit that you are seeing your patient for. And so, you know, if you would like a copy of this algorithm sent over to you, please send me an email and I'll be happy to send you this document. But if you can see on my screen at on the chart itself, I've given you some tips on which codes to use under what circumstance. So if you're doing video communication, you would be using the codes that say this is telehealth. Use E&M codes 99211 through 5 for established patients, 99201 through 5 for new patients. But you can also add plus the other 225 or so CPT codes that can be done by video telehealth. All right. Now, if it's a written communication, then you're going to use the e-visit codes 99421 through 423, And if it's telephone communication, it's 99441 through 99443. And so, you know, if all you're doing is reviewing some imaging reports, you would use the virtual check-in code G2010. And if all you're really doing is checking in with the patient to determine if they need to come to the office, then you would use code G2012. Now let's talk about a few of the rules to make sure that you guys get paid for what you do. And I've had some providers contact me and say, hey, I'm billing these and I'm not getting paid. And probably the reason why you're not getting paid is you're not following the time frames for these codes. So these codes can be billed, but if, for example, the virtual check-in, if the virtual check-in is done within 7 days of a telehealth visit or 7 days of an in-person visit, then that virtual check-in code is not going to be paid. If the virtual check-in results in an office visit or a telehealth visit within 24 hours or the soonest available appointment, so let's say, you know, you're listening to this tomorrow morning and you have a virtual check-in on Thursday morning and you schedule the patient for a telehealth visit or to come in on Thursday afternoon, you won't be able to bill that virtual check-in. You're going to have to go at least 24 hours out for that next appointment in order to be able to bill for that virtual check-in. On the back side of it is, let's say you've done a telehealth visit and you've ordered a brace for a patient and you've done a telehealth visit to help them put the brace on. You've done the fitting virtually, and now 3 days have gone by and you want to do a virtual check-in with a patient to make sure that the brace is fitting correctly, they're not chafing, they're not having any problems with it. That virtual check-in code won't be paid because it was within 7 days of that visit. So be aware of your time frames. The other thing is that your virtual check-ins must be done by a qualified healthcare provider. That's a takeaway that you need to be aware of. So this isn't something that, you know, your staff can call and schedule an appointment. This is literally a virtual check-in. So the staff can call, they can talk to the patient, they can see if the patient would like to check in with the doctor briefly, but then the doctor or the healthcare provider needs to come on the phone and give a verbal order for the patient to come in, and maybe to have a brief discussion over what the patient's needs are. So make sure that that is documented as such. During the public health emergency, these virtual check-in codes can be used because they're telehealth codes. They can be used by PTs, OTs, and STs. Now, the telephone E&M services, there have been some significant changes to that. CMS will pay for phone calls now using 99441 through 443 and 98966 through 98968. The rates for the 441 through 443 codes were increased to match the rates for 99212 through 214. These codes can be used for new and established patients during the public health emergency. Now, for those of you who are coders, that may be blowing your minds a little bit, because we know that as the coding rules for new patient office visits, outpatient office visits, require 3 key components: the components of history, exam, and medical decision making. Well, during this COVID crisis, the healthcare emergency, what has happened is the Medicare has adopted the rules that are going to be in place in 2021, which require only time and medical decision making to be the qualifying factors for an evaluation and management code. So that means that if you record the time spent with the patient on that virtual visit, and then you record your medical decision-making findings, you'll be able to bill for a new patient exam, which is pretty neat. If you're a physician, a nurse practitioner, or a physician assistant, you would use codes 99441 through 99443. Other qualified healthcare professionals, such as dietitians, social workers, speech language pathologists, and physical therapists, would use for their telephone services 98966 through 98968. And these are telehealth services, so that means place of service 11, modifier 95 would apply, okay? Now, one thing also to remember is that your telehealth services, as I mentioned earlier in the presentation, are patient-initiated services. It's as if the patient is coming to you, except they're coming to you by the telephone or by video. And so you make sure that they have initiated that call. If you call them, it's not considered the telephone service. Now you can call them and remind them and say, hey, just want to remind you that your call is in 5 minutes. Please call in to this number and the doctor will pick up and talk to you. Okay, you can do that, but you can't bill for that. So just make sure that the patients are making the calls and that you're documenting it as such in the patient's record. All right, so, how can telehealth help you as you're getting back to work? You're seeing patients, but you're having to spread them out so you can sanitize and protect them from possible contamination. So one of the things that I want you to think about is really explore with your staff those virtual options. What are some of the things that you can do with a patient before their visit, before they actually show up for that adjustment or show up for that injection? So, for example, maybe you can do a consultation, write orders or referrals, do the new patient intake, the history. And remember that if you do the new patient intake history under the virtual check-in or under the telephone evaluation and management code, it can be reviewed by ancillary staff over the phone, but then the provider would have to come on and confirm that. So, there are just some logistical things that you'd probably want to be talking about as to how you're going to do these and accomplish these in the office. Let's also talk about Part B and DME after COVID-19. So many clinics over the last few months now have taken advantage of the provider enrollment flexibilities for same-day Part B provider enrollment and expedited DME enrollment. These flexibilities are still in place until the public health emergency is lifted. And the DME, one of the things that we are finding, and our company has been doing quite a few of the DME enrollments with the AMI clients, with our own clients. We've probably done about 30 of them over the last month or so. These are taking longer than originally expected. Medicare said that a clean DME application that was submitted electronically through PACUS would take about 7 days. A paper application, about 14 days. Unfortunately, PACUS kind of blew up a little bit and there was a problem with the website. And so what happened was all of the documentation, the supporting documents that we had to upload to PACUS was not viewable by the enrollment specialists. And so the enrollment specialists had to send out letters to all of the applicants stating that they needed to have those documents emailed to them directly. So every single DME application after a certain date in April ended up going under what's called development, meaning it wasn't a clean application, even though it was, the website wasn't working. So maybe too much information, but just an FYI, these DME enrollments, expedited enrollments, are taking a little longer. It's usually taking 2 to 4 weeks for the expedited enrollment online, and maybe a little bit longer if you submit it by paper. But it's still a whole lot shorter than the 6 to 12 months prior to the expedited enrollment provisions. Now, and remember that if you are a provider or a supplier and you received provisional billing privileges from Medicare, you are going to have to be to do the complete enrollment and complete your enrollment once the public health emergency designation is over. And so let's talk about a little bit about how that's going to work. So according to CMS, once the public health emergency is lifted, you as a provider will begin to receive notification. It's unclear now as to whether that's going to be by letter, email, or both, that you have 30 days to complete your application. So you're going to get they're going to draw a line in the sand. They're going to say, okay, from this date, if you don't do anything with your enrollment, if you don't move forward with permanent Part B enrollment or complete the DME application by submitting your application fees and initiating the accreditation process, then we're going to drop your enrollment. You're going to have to start all over again, which you do not want to do, okay, especially under the DME supplier. And under Part B, it would mean that your providers would no longer be able to render services to the Medicare patients after a certain time. For Part B, what you'd have to do is fill out an 855I, that's the name of the application for an individual, 855B for an organization. As a DME supplier, you would have to pay the enrollment fee if you are taking the non-accredited route, and you would have to initiate the accreditation process if you are going the accredited route. Now, I did a webinar on this a few weeks ago about the differences between non-accredited and accredited. Suffice to say, if you're a chiropractor and you own your medical group 100%, you're going to have to go through the accredited route. If you have a medical doctor or a DO who has at least 5% ownership in the medical group, or you're a medical provider and you're listening to this and you own the medical group 100%, then you can go the non-accredited route. And the non-accredited route is much simpler than the accredited route and much cheaper, so about 10 times cheaper. So the non-accredited route, you just pay the $595, $600 application fee to Medicare, and you'll have to go through a background check, you'll have to go through a site visit, and then then the enrollment would be complete. For the accreditation, you have to partner with an accrediting organization, a deemed accrediting organization. It costs about $5,000 or more to do this. And you would need to contact them and get signed up with the accrediting organization within that 30-day time frame. So how do we prepare for that? If you are going the accreditation route, I'm going to encourage you to start saving up for that now so that you don't get caught unawares whenever the public health emergency designation is lifted. And I mean, at some point it is going to be, we don't know when. You know, we don't know how much of a grace you're going to have to be able to sell these DME supplies without going through this accreditation. So, you know, there's just some suggestions would be for the bracing, for example, you're going to get reimbursed about $1,200 for an LSO, a back brace. Your cost is about $200. You know, that's $1,000 profit. So if you took even half of that and just set aside half of your profit from the first 10 braces that you order, you could pay your accreditation fee. So that's something that you could think about doing. Some of you have received EIDL funds from the SBA. So if you received an EIDL loan, you may want to set aside some of those loan proceeds for the accreditation fees. And also you may need to be prepared for certain physical plant modifications, such as a public display of your product. So typically, because if you're going the accredited route, you're setting yourself up as a medical supply store, which means you have to have your product on display. And you don't have to have a lot of inventory on display, but you might have to have a brace, your knee brace and your back brace and a TENS unit. And so you're going to have a display area in a public part of your practice, which would be the reception area, where you can actually display those braces and the prices for those braces. Because as an accredited organization, anybody can walk in off the street and buy a brace from you, and you can bill Medicare for it. As long as that patient walks in with a prescription from their doctor, you'll be able to order that brace. And so that's just something that you need to be aware of. So you may also need, the accrediting organization may want to see that you have space for your inventory and that your practice meets ADA requirements. So if you're, practicing in a building that was grandfathered in to where you don't meet ADA requirements, you may have a challenge getting the accreditation through. So those are just some of the things that, I wanted to talk to you all about today. And these are just kind of updates to keep you apprised as to the most recent changes that are going on with Medicare, with provider enrollment, with telemedicine. Hopefully this gave you some food for thought on what you need to do to get back to work and you utilize these resources that are still available to you for who knows how long, as you begin to start seeing your patients again. There's all kinds of opportunity and all kinds of configurations that you can do in your practice that will help you ramp back up to full speed ahead. So thank you for your attendance. For those of you who have billing or credentialing, need credentialing help, or would like some training for your staff, or you have compliance questions, I'm offering a complimentary 30-minute consultation. You can call me or you can email me, and we can get that set up for you here in the near future. For questions on medically integrating your practice or regenerative medicine, please contact AMI. They are the absolute best at what they do, and they have what I have seen as far as the AMI doctors who have been able to not only survive but thrive during this public health emergency is just nothing short of miraculous. I am so impressed by the hard work that the AMI consultants have put in to keep their clients working and profitable and just systematically moving through this process and not losing their practices, and and in some cases even growing their practices. And for questions on DME and supplies, Azon Medical, some of the best folks out there for helping you implement DME in your office and in your practices. Feel free to give them a call. They're just amazing. And so again, I want to thank you for your attendance. For those of you who would like to access prior webinars that I've done, you can go to my website, goldstarmedical.net, click on the webinars tab, and then click on the drop-down menu called Webinar Archive. Some of the topics that relate to this whole COVID-19 pandemic include how to implement telemedicine step-by-step, provider enrollment step-by-step during COVID-19, how to bill for DME bracing, and other topics as well. So this concludes our presentation today. I want to thank you so much for your attendance and for your attention. I hope you all have a successful rest of your month. I hope you all stay safe, stay healthy, and God bless. Thank you so much.